stories shaped our past and illuminate our present. Yet now, as new challenges arise and the world evolves, their mission faces its greatest test yet. Be part of our journey and let's navigate the unknown, uncover the untold, and safeguard our future together. Tune into your public broadcaster, for it is the intersection of trust and truth. Because to UBC, your story, and every voice matters. UBC, inspiring Uganda.
Welcome to Chirudu National Referral Hospital, and this is our ICU. Our ICU was developed and started in 2021 in response to the COVID-19 epidemic, and we started originally with 3 beds. We started as a 3-bed ICU, but as we could not fulfill the needs for the entire hospital and for the country, the ICU was expanded to accommodate approximately 9 beds. We usually manage patients who have respiratory failure. That's patients who are unable to breathe on their own. We're able to place them on our machines known as the ventilators, and we're able to give them support. We're also able to give critical patients critical care in terms of advanced life support and such. We also receive patients from around the country who have a number of issues such as kidney issues, who we are able to help with dialysis and other support as well. Currently we have a capacity of 9 beds. We do try to improve, and we do try to build our capacity to have more patients.
A very good morning to you who is still hooked up on UBC TV. Thank you so much for keeping it with us. My name is Sophia Matovu, and right now it's the Health Q&A. Chirabo, thank you for taking us through GMU Extra, and the topic, of course, that he was talking about is very important, condom use, because it's something that we have dropped. But I have beautifully tailored my words here to give you a bit of what we are talking about. Now, when illness becomes critical, doors close, machines take over, and families are asked to wait. Now, behind these closed doors is the intensive care unit, a place many fear, few understand, and some only encounter in moments of crisis. Today, our topic of discussion, as you can see is displayed on the screen, is inside the ICU. What really happens behind the closed doors? I normally tell you, I'm not the expert. I endeavor to bring the experts here for you in studio to be able to open up on these topics. With me in studio is Dr. Alvin Ntambi, who is an internal medicine specialist, and he is the head of ICU at Chirudu Hospital. Good morning, doctor.
Good morning, and thank you for having us. I think I must commend you for taking this initiative up, because people do not know what goes on in the ICU, and I feel from this program we will be able to shed more light on what actually goes on, and maybe allay some anxieties people may have, and maybe spread more knowledge about what goes on in the hospital.
Okay, thank you so much for making it. Another doctor with me in studio is Dr. Pitch Kabata, an intensivist. That's a rare terminology. He's an intensivist and a physician at Chirudu Hospital. They are going to help us to understand one of the misunderstood spaces within the hospital environment. We're used to walking into the general wards as and how we please, but you're asking yourself, why can't I access ICU, and yet that's where my patient has been admitted? First, I'll get to you gentlemen, the doctors, the wonderful doctors who spared your time. What exactly, break it down for the layperson, because they'll just say, eyo mkasenge yo, and they're not allowing us to access that kasenge, that closed door. Break it down for the layperson to be able to understand.
Okay, thank you for that question. I would first start by trying to inform the general public and everyone that we're all candidates for an ICU admission. We're all candidates for a hospital admission. So we're all affected, and we're all likely recipients of healthcare. So an ICU is basically a specialized unit in a hospital, and it's a unit where we do what we call maybe life support, in simple terms. We receive patients who have life-threatening illnesses, patients who ordinarily could not be taken care of on the general wards. These patients have a number of complications which come from different illnesses, and we take them up. Ideally, we take them up to support organs, that is, organs like the heart, organs like the kidneys, and organs like the lungs. Commonly, we have had a number of patients who come to us who
need what we call respiratory support. If you recall, about 6 years ago, we had the COVID-19 pandemic. And a lot of, I think almost everyone lost a relative. COVID-19 or severe pneumonias tend to cause what we call respiratory failure, a situation where your lungs or your breathing system cannot function to a level that is adequate to you. So we take such patients up and we are able to give them what we call respiratory support. That is, we use certain machines called ventilators. If you've ever had people talk about ventilators, I'm pretty sure you've had something like that. It's a machine that is able to take air or oxygen and put it into your lungs. So we are able to use different machines in the ICU to basically support these different organs. And that's a small bit, but the general idea of what goes on in the ICU.
Okay.
Yes.
Dr. Presh, would you like to add?
Yes, thank you very much, Sophia, for having me here and for inviting us. Yes, just to reiterate what my colleague Dr. Alvin has said, in the intensive care unit, it's essentially a place where patients come in for organ support or monitoring. So, for example, the monitoring aspect, if someone has had, let's say, a major surgery, they can be taken, after the surgery, they can be taken to the intensive care unit for monitoring. Or let's say you have someone who is ill and you're concerned that their condition might progress in the next hours or so. So you can also bring them in the intensive care unit, basically to monitor them. So people come to the intensive care unit either for organ support, as my colleague has said, or basically for close monitoring, because number one, you suspect they might deteriorate, or let's say they are from a major surgery and you still need to monitor them as the drugs that they've been given wear out from the body.
Okay, so I'd like you to explain to the layperson what happens typically within that 24-hour the person is in ICU. Of course, they'll be there for possibly a number of days, but what pretty much happens? Because on the general ward, you're used that maybe the doctors will do the morning rounds.
Yeah.
They might have others coming like at around the lunch hour and possibly in the course of the day, and they will know that they live properly on the chart prescription of maybe you need, one needs to get maybe transfused, one needs this medication, one needs to be discharged. How different is the general ward from ICU?
Okay, the ICU is first of all a closed door unit, but I can take you from the angle of a patient when they're coming in. Usually we are alerted to expect a patient. Usually we go and if the patient is in-house, for example at us at Chirudu Hospital, if they're in the different wards, we do go and assess them on the different wards they may be, maybe they're in the emergency unit or different wards. So we assess them and we confirm that maybe they actually do need the ICU. So when a patient comes to the ICU, the first thing we do is move them from the bed, because most of the times these patients are unable to walk on their own, they're quite sick, some are not conscious. So we move them from the bed that has been brought, we transfer them to an ICU bed. We assess their needs. For example, how is their breathing? Is their breathing adequate? Does it need a higher mechanism or mode of oxygen delivery? You hear people talk about my patient was on oxygen. So sometimes when a patient is taken to hospital or on the general wards, they are put on some kind of device, which is maybe goes around the nose and delivers oxygen. But while that may be a good system of delivering oxygen, there are better ways and better modes which can give you more oxygen. So in the ICU, we have those machines which I had spoken about earlier, and they're able to give you much more oxygen or much more air. So when a patient comes, we assess their needs, their breathing. Do they need to be hooked up on our ventilators? If they do need, we take a number of steps to place a tube into their airway. And this is quite uncomfortable. This is why sometimes we have to sedate or give them some medication that makes them sleepy or makes them calm, so that we can place a tube inside them and breathe for them. Basically, we take the work of breathing patients away from the patient so that they can focus on healing. When they come, we hook them up to a number of monitors. When you come to the ICU, I'm sure you hear some beeping, and it makes you a bit worried. But you shouldn't worry. That beeping is actually showing you that some constant monitoring is being done. The beeping is from the monitors, and we have other should I call them delivery systems that put medicine into the patient. Those are what you hear, the beeps, the constant beeping, the alarms. They're telling you, is the medicine moving? Is it stopping? How is the heart beating? How is the breathing going? Do you need to change something? So they alert us. They may seem noisy, but they're actually quite important to us because they're telling us what's going on the patient. Yeah.
Yes, and just to add to what my colleague has said, the first 24 hours is very important for any patient. Let's say, for example, someone has come in and they have a severe infection, and by the time you get them to the intensive care unit, you could have that their blood pressure is on the lower side. So normally, as we sit here, we're maintaining our blood pressure, we can talk, we can discuss. But as your blood pressure goes lower due to things like infection, you can become a bit sleepy and you're unable to do such things. So the first 24 hours, especially when someone has just been admitted to the intensive care unit due to a serious life-threatening illness, it's normally a very delicate time whereby we need to figure out, okay, let's say the blood pressure system is not working very well, we need to support it. The breathing is not working very well, we need to support it. The brain is also having some challenges and we need to support. So the first 24 hours, especially after a critical illness, when you're just admitted to the intensive care unit, that's a time when we really try to stabilize the patient. We first stabilize them to make sure at least they're out of the acute sense of life-threatening impending illness, and then after that we try to support them.
Okay. Now, why is access so restricted as opposed to the general ward? That's what the lay person is very confused about. You know how we're used to our African kind of setup, not like the European where, you know, you drop your patient in the hospital and you can always just go by, but not necessarily hang around and even have your mattress besides there, keep supporting them with drinks or whatever, keep checking on them and touching them. Why is it that restricted?
So if I could start with that, access is restricted for multiple reasons. So let's say, for example, in Chirudu currently we have a 9-bed intensive care unit. Now, when someone is with us in the intensive care unit, there is around-the-clock monitoring. So meaning every time we are looking at the numbers the person is giving us, for example, the blood pressure, the heart rate, the oxygen levels. But then if someone is in the intensive care unit and they're having all this, there's also a bedside nurse. A bedside nurse is by the patient, and the bedside nurse does multiple things, including turning the patient, feeding the patient, and all these things. Therefore, if you have an attendant right by the bedside, as in the general ward, the care can actually be hindered by the patient because every time you will have to go around the attendant and everything. But then also there is the effect of infection. Alvin will speak on.
Oh yes, thank you for that question. And I think the general public needs to know this. I think we've all had a patient in the ICU at some point, either a relative, a friend, a colleague, maybe a co-worker. An ICU is a closed door unit, and we try to keep it closed for a reason. As my colleague has said, one of the reasons is infections. You see our hands, which we walk around with, they carry a lot of bacteria or a lot of germs. And an ICU patient is one patient who you would not want to have exposure to unnecessary germs. I understand when you get a patient in the ICU, you may want them to, you have anxiety, you're worried. How is the patient? Is he receiving what he needs? Is he receiving food? Is he, you know? But once the patient is in the ICU, we have to keep the doors closed so that people don't come, firstly, to interrupt or to distract the health workers from what they're doing. And even when we do allow some people to come in, we tell them to say, maybe to wave to their patients. They're not supposed to really get so close because they bring in infections from outside. Although we do try to make sure that we control the infection and make sure people come in, they wash their hands, they wear face masks, still, there's bound to be some bacteria or germs that can find their way to the patient. So we try to keep it closed because it's an intense unit. We're doing a lot and we don't want any interruptions or distractions. I completely understand a relative saying, what's going on, they're anxious. But we should always try to enlighten them and let them know what's going on. And that's why I think this program is quite important, because people don't have proper guidance on what goes on. So that maybe can explain why we don't let people in, or the doors are always closed.
Then I would like you to break it down for me within from the time the patient is brought in how and who is responsible for what? Because if you say a lot is happening, like I explained earlier, on the general ward, they will know the routines of what time the doctors come through. How different is it here in ICU?
Okay, on a general day, maybe I can give you what a 24-hour day looks like for me.
Okay.
Let's say we start our ward rounds are between 8 and 9. We usually arrive between 8 and 9, and we receive a report from the team that has been there at night. So we find patients who have been already hooked up to our machines. And you know, these patients can't move. Some of them are in coma, some of them are sedated, so we have to do the work for them. For example, cleaning them. We have each ICU bed must have a dedicated nurse. And that's why an ICU is different from the general wards. The ratio of nurses to beds is quite high in an ICU compared to the general wards. So you'll find the patient has to be cleaned, the mouth has to be cleaned, the body has to be cleaned. The patient has a number of tubes that are going in him and taking out. You know, you've heard of urinary catheters, you've heard of feeding tubes. They have other tubes that take in medicine, larger tubes compared to the cannulas that you've been used to. So on an average day, we go and have a ward round. We assess the patient because we must assess them and come up with a plan. Maybe we need to step down the medicine. Maybe we need to step up the medicine. Maybe we need to do some investigations. So on an average day, in the morning, during a ward round, we come up with a plan for the patient. After the ward round, after I've seen all the patients, what usually happens, we divide ourselves. So all the nurses go on the different patients. They do what we call oral care, where they clean the mouth. They do general cleaning of the patient because they're unable to move. They have to turn the patient, position the patient. They do most of the work that a patient would usually do for themselves if they're on the general wards. You see us sitting here comfortably, but trust me, when an illness gets you, you will not be able to move your body. You cannot be able to help yourself. So one important thing that takes place in the ICU is nursing care. And I think our nurses should be really commended. They do a great job while they're there. Because imagine you're in a place, you're not related to anyone in that unit. They're strangers to you, basically. All your relatives are outside. And you entrust them with taking care of your relatives' entire person. So I think that is basically what we do on an average day. Yeah.
Yeah, okay. And also to add on to that, as my colleague has said, after the general ward round and basically saying, distributing the different personnel who will work on the different patients, there are multiple other things that go on during the day. For example, as the day goes on, you might get referrals from other units. They might reach out to you and say, we have a patient in ward X and would like you to come and see, and you follow up on that. But then also, the intensive care unit normally has two models. You have a closed unit and an open unit. A closed unit is where the intensivist makes all the decisions of the patient. But let's say a patient has been admitted from the renal ward, the ward that deals with people who have kidney problems. The referring doctor still has authority over that patient, and they'll actually even want to come and engage with the patient. So after the general ward round of the intensivists, we also invite other teams to come in and see the patients who they referred, and they follow them up, in addition to picking up other referrals from the units, but then also doing the jobs. And apart from the jobs, I mean, let's say in the ward round you have said, we need to send blood for culture, we need to send urine for tests. All those things are done during the day, but then importantly, when they come back, you have to review those results and see what's going on. And if you have instituted, let's say you have said, the patient's blood pressure is low, we are going to give you something to increase the blood pressure. If you do that at 8 a.m., at 12 p.m., it might be a different story. They might need a lower concentration. So every time you come and see the intervention that you have done, and you see how you can titrate it to the needs of the patient at that time. So it's a continuous process throughout the day with multiple iterations of finding out what does the patient need at this time.
Now, how do you fully involve the family so that all the relatives to ensure that they are not left out, you know? Because of course, I know there are hours where you will identify a particular one, maybe it's the spouse, and the spouse will have access, but there are times when they just don't seem to understand what is going on. How do you break down that information for them? And also, in terms of when they enter there, they have possibly high expectations that since there is that it's a critical care and all that is taking place, then the person is going to come out alive. How do you break it down to them to know that it's a chance where it's this because we are just trying to support the organs?
Yeah, so if I could start with that, I think the most important thing to understand is that if someone comes to the intensive care unit, especially due to a critical illness, it means that the care that they are receiving on the ward might not be sufficient, and therefore they need a higher level of care, closer monitoring in the unit. So essentially, by coming to the intensive care unit, it means someone already most likely has a life-threatening illness. And therefore, from the very beginning, the intensive care unit is where you balance hope, but then also with realism. You have to be very real, but then you're also balancing it with hope. And that's why, for the families, we always try to make sure that there are regular family conferences. So a family conference is whereby you sit down with the family members and say, your loved one has this and this disease. He or she needs this and this organ support, and we're trying what we can do. However, because of this level of illness, there is a chance that they may actually not make it. Okay? So you're balancing hope and realism. And I think the most important thing in the intensive care unit is to always be very truthful to the family members. You tell them the truth, and you tell them as it is, but then in a humane and delicate way, so that it is not a place for miracles, if I may say. It's not a place for miracles. It's just a place where we keep having family conferences to update them on what is happening. I don't know if my colleague can add something.
Yes, thank you, Dr. Preach, for that. So to add on to what he has said, we all have loved ones, I would say. And once they're placed in the ICU, we don't have, should I say, regular access to them. That in itself makes the relative anxious. That in itself makes the relative anxious. On our part, as the health workers or the doctors or the team that is looking after the patient, we try as much as possible to share information. The information may be unpleasing, but we try to communicate it in a way that you understand what's going on. We try to be optimistic because, like I had said earlier, we all had a relative or a friend who has been in an ICU. Similarly, our entire team has been in the same position. So we try to put ourselves in the shoes of the relative. Try to speak to them as if it were us on the other side. Try to share with them the information that they need to know, and try to be optimistic as well. So we have to balance the act, but we try as much as we can in the daily family conferences, which we do. We have maybe about 10 minutes with each relative, with each patient's relatives, where we discuss the condition at length. We ask the patient's relatives what are their ideas about the patient, what are their expectations, and what are their concerns. If they have some concerns, we try to address them. If they have some expectations, we try to either dispel them or try to encourage them. The ideas may be wrong. Some people may come with an idea that my patient was bewitched, or my patient had this, or so we try to put the science in layman's terms to them and tell them what's actually going on. Sometimes it's a bit hard because some people don't want to understand, or some people have different levels of understanding, because everyone is different.
True.
So we try to put the message across in a way that they can understand. And I think that's what's called good communication between a doctor and the patient or the patient's relatives. So we try to do that on a daily basis.
Now then, let me reverse, because now we're talking more about the family. How do you, as the team in the intensive care unit, detach us, because there are certain times there are emotional attachments. You're working in a unit where it's, how should I say, a 70, I would not say 50-50 when somebody's brought to intensive care, because if most of the organs need support, where let's say it's a 70-30, and you know, like if you have the 9 beds filled up, chances of how many patients will walk out of there alive, how many will die? How do you emotionally deal with that as a team, and how do you try to see that maybe, I imagine there's certain times you might get attached, depending on how long the patient has been on the bed and how you've been communicating to them. Have they been responsive? Then what has eventually happened?
I'll answer first on that one. We have a number of, we're human beings as well, the health workers. We're bound to get attached to the patients we're working on. So I'll give you an example. There's a patient we had who was with us in ICU for 3 months. 3 months, had a debilitating illness, could not breathe on their own. So every day, but luckily for him, he was able to speak. Ooh. He was able to speak. However, he was not able to move the rest of his body. So on a daily basis, we'd come and actually speak with him. ICU patients most of the time don't speak, but in this case, or in some cases, he was able to speak. So along the way, we did get attached. And we have to accept the fact that we're also human beings. And I feel that attachment, that feeling that we're also human beings, I feel it makes us better as health workers. And it gives us a better appreciation and also encourages us to work better on the patients. So I think it's a plus. I think we need the emotional attachment to the patients. Maybe the level can be what is a bit different, but it's very important. So you said earlier about a 70-30 probability. Globally, this is a global statistics. An ICU admission has about, I think the global rates, if you go on average in the countries throughout the entire world, it's about 50%. So out of the 10 people who go to an ICU, maybe 5 are going to make it out alive, but this is just estimates. And maybe for different countries, the estimates may be different. So when you do go to an ICU, you must understand that the people who are there to fight for you as well. So us as a health worker as well, we're doing our best, our level best to get you out of whatever life-threatening illness you may have, trying to support your organs, trying to buy you time to heal, and try to transition you. There are a number of patients who we get and we actually feel so good that we have worked on them. There's a patient who received, I think, last year, a young lady who unfortunately got a life-threatening illness where she was unable to breathe on her own. She got a clot, what you could call a clot. In common sense, in the layman's terms, she got a clot and was unable to breathe for her own. So we spent time with her. We got her out of that failure of breathing. And we started talking with her. And you could see she was doing certain activities prior to admission that actually got her there. And you could feel the anxiety herself she had. She was worried. She also wanted to come out of the ICU and live her life. A young lady wanted to finish school, wanted to have a kid. So there are those different stories which we are exposed to. And I feel as health workers, it's better for us to have an emotional connection with the patients because we work on them as if they're our own relatives.
Yeah, true.
Yeah, we give more input, we try our level best, as I had said earlier. So I don't know what you can...
Yes, just to supplement what my colleague has said, yeah, indeed, I think over time you come to realize that even though you have seen people passing on multiple times, it's always new for everyone. And sometimes in such cases, there's something called a debrief, whereby you sit with the team that you have taken care of this patient for this time, and you just talk over it and see what happened and see if anybody needs any further emotional support. If in case someone gets very emotionally affected due to someone's passing on, it's very highly recommended to also speak to someone who is more knowledgeable in such things. So clinical psychologists are also very helpful in helping the healthcare workers deal with grief and loss of patients, just as families are very important. Families are also encouraged to seek psychological care. Healthcare workers is also very important to seek psychological care, especially when you have lost someone and it really affects you. But a debrief, when the department sits down and talks about what happened, that also helps allay the anxiety and helps unload the team. So speaking about it as a team is also very helpful.
Okay.
Yeah.
Our WhatsApp line is displayed on the screen for you. You can participate in the show. You can ask the doctors your question. This is the time right now where you can always drop in your question or your concern, or you can contribute to the show in whichever form you feel is appropriate. Now then, there's also a bit where the layman has never seemed to understand. Gladly now for me, as we sail along the way, you can be able to understand why the cost is the way it is. But I'm not going to speak for them. I'd like you to be able to explain to them why it's so expensive. They will not seem to understand it. It's like an arm and a leg per day.
So I think it's a delicate topic, but how I can bring it out? In the simple terms, regardless of if you're in a public hospital or private hospital, an ICU bed, the running cost of maintaining an ICU bed, this is before you go into procurement. This is before you go into construction. This is before you go into buying them. This is, sorry, after you've bought all of these. Let's say you've bought your ICU bed, you've put your ventilator, you've put the different accessories that accessorize an ICU bed. The cost of maintaining that bed on a daily basis, 24/7, because an ICU is a 24/7 unit. One single bed can cost between 2 million and 4 million per day. And that's why people when they go to certain hospitals, I'll speak for the general public, for those who are in private and maybe in public as well. In private hospitals, you'll find an ICU bed per day costing between 2 and 4 million shillings per day. This is because of the specialization of the specialized machines that are being used, the accessories that are being used, should I say the consumables that are being used, because an ICU needs a dedicated oxygen supply. An ICU needs a dedicated water treatment plant which provides distilled water, which is used to clean machines, which is used to clean sterilize equipment, and it's also used to do certain procedures like dialysis. So all in all, when you put that together, the cost of an ICU bed is quite expensive. I won't go into detail about how expensive a bed is, because it's quite expensive to just buy an ICU bed. An ICU bed is quite different from a general bed. There are a number of things an ICU bed can do. It's a mechanized bed. It's able to tilt a patient. It's able to weigh a patient. It's able to quickly revert to a position if you need it to. Then there are other things that come in to accessorize it: the monitors, the ventilators, the pumps, the syringe pumps, if you hear those beeping machines, the infusion pumps. These machines are all there to take care of a patient in a constant way. Constantly monitor, constantly give medicine, constantly give oxygen. So that entire process is quite costly to maintain. That's why the ICU cost in certain places is extremely high. But for us in the private setting, sorry, in the public setting, that is through the hospital, the government has done a very good job. Whereas you'll find an ICU bed per day in private institutions between 2 and 4 million, the government subsidizes the ICU admissions in public hospitals. So you go to the different hospitals in the country that are run by the government, you find a very subsidized cost for an ICU. Yeah.
How easy is it to shift somebody from one facility to the other? Because, you know, we've had a lot of scenarios where people rush first the person to an ICU bed in a private hospital, and then after that they want to rush them to the government one. But at that time, possibly when they put this person there, because they didn't have the space in the government ICU bed. Now they want to switch the person to the other side because they've managed to get a bed and it's much more affordable.
Yes, about the affordability, just as I come to answer your question, my colleague has described the running costs of the equipment and etc. And you need to remember that all these need electricity. But then there's also the healthcare workers at the bedside. So let's say you have 2 nurses per day running 12-hour shifts, then you have 2 doctors per day. So there's also the human resource cost, and then there's also the tests that are run. About transferring patients from private hospitals to public hospitals, when I was still the head there, I received multiple calls, and I'm sure my colleague, the current head, is also receiving multiple calls. There's something called equity. Equity is basically is what is very important in such a situation, because you can imagine, even as they're trying to refer patients from the private hospital to the public hospital, there are also other patients who are already in the public hospital who are requiring the ICU space. So how do you balance the two? However, in situations where there's an available bed And an available bed basically means, yes, the bed is there, yes, the nurses are there, and the equipment for that patient is there. It's normally easy to accept, and there are multiple patients we have accepted from private hospital to public hospital. But the first thing is they need to call the in charge of the unit to find out if there's a bed. And a bed does not necessarily mean a physical bed. As I've explained, there needs to be a nurse assigned to that bed. There needs to be adequate resources for that bed. Then they can be transferred. But the bottleneck comes in is that there are also patients in public who also want that bed. Yeah, so that's where the bottleneck is.
Okay. How complicated is it? Because I can imagine if this person is not able to support themselves up to the breathing, yes, I know there is the oxygen, but with the other, you know, everything connected and wired to them, now shifting them, how easy is it?
And that's a very good question. The transfer of a critically ill patient is one of the dangerous times in the intensive care unit. Because think about it, someone can be having a breathing tube, it's helping them breathe. As you're moving them from one bed to another, let's say from the bed to the stretch of the ambulance, the breathing tube can come out. They have multiple lines that support them in terms of giving the, let's say, blood products, giving drugs, and they can also come out. So the transfer of a critically ill patient is a very delicate and dangerous time for the patient. And therefore, the transfer of the critically ill patient is normally done by someone who's very experienced and trained in that to ensure that the transfer is safe. Because during transfer, so if someone has been in the intensive care unit, they're critically ill, as you're transferring them, their critical illness has not changed.
True.
They're still critically ill. So essentially, you are transferring an ICU for that patient, still needs an intensive care setting. So they need a bedside nurse, they need a doctor, they need all the equipment running. So it's a delicate time and a dangerous time. But with adequate training, it's normally done flawlessly most times.
Okay, now we have, good morning, my name is Tommy Okot from Kabera Biong district. Kindly, what happens to a person admitted to ICU that makes his or her nails grow so fast?
If I could try to answer that. Well, that's a very good observation, but it's the opposite. It's the opposite. Interestingly, the rate of nails growing is known. It can be sometimes up to, it's in the internet, people can look it up. It's almost about 0.1 millimeters per day. If someone has had a very critical illness, interestingly, their nails actually stop growing. And when they're out of the critical illness, their rate of growth can continue. And if you look at the nails, sometimes there are some lines. We call them Beus lines, B-E-A-U apostrophe S, Beus lines. So critical illness affects everything. If you're very ill, it affects everything, including nail growth. And sometimes you can actually look back and you see there's some, not the common lines, the specific lines called the Beus lines that actually happen in case of critical illness.
I can also add on to that in the sense that when an ICU patient is, looks different from when he was outside.
Yeah.
They have other illnesses as well. Sometimes you can come to the ICU, maybe you had not seen this person who is your relative, and then you find them in the ICU and you find their face or their body is all puffed up. That could be because of a number of reasons. Maybe because the kidneys are not working as they should, maybe the liver is not working as it should. The color of the body can also change. You'll find situations where they become pale, situations where they have low blood levels or anemia, or they have liver damage and their skin color changes as well. So a patient, regardless of if it's an ICU patient, is bound to have changes. And there are a number of reasons that are responsible for these changes to their appearance. Yeah.
Then, who determines how long somebody stays in ICU? Because there are certain times you'll find families having closed meetings and they have possibly, maybe with the guidance of the doctor, I beg to be corrected, have been told that, you know, chances of survival are minimal. Do you still keep the person going? How do you go about that particular closed decision?
Thank you for that question. The duration of ICU stay is multifaceted, and it is due to many factors. One of the very common driving things is the reversal of the cause of being brought to ICU. For example, let's say someone has, during the time of COVID, because everybody remembers COVID, someone comes in and they require oxygen support. As we sit here, we are breathing about 21% of the air is oxygen, and we're happy with that. If your lungs are not working as expected, you might need higher oxygen support. So if someone comes in and let's say they had COVID and they have been given oxygen support and over time they have gotten better, then the treating doctor, the intensivist, will assess every day how much support does this person need. Let's say they came in and they required 100% oxygen to give them an oxygen level of about 95%. Now, if on day 5, what you require is 30% to give you that same level, then that's a good thing. And let's say by 7 days you only require 21% room air to give you what you need, then that's okay. So one of the key driving factors for the length of intensive care stay is the reversal of the cause of admission. So if you're admitted, let's say because of acute kidney failure and you needed a lot of support, as the organ is being supported and there's reversal of the cause, then that one can determine how long you stay. One of the patients who he has mentioned, I knew him. He stayed with us for 3 months. He had a problem of a disease that affects the nerves and he couldn't breathe by himself. So if he can't breathe by himself, he still needs a level of intensive care support. But then, to be honest, there are also other factors that determine the level of stay. For example, if the cost is becoming very high and the family can no longer afford, that can also affect. But the number one driver is the reversal of the cause of the intensive care admission. I don't know how I can add.
Maybe add on that as well. But you also asked, maybe the family has been told that there's no hope or something to that extent. So we do have situations like that where we have a patient who we know is unlikely to make it. Actually, I think maybe if I say if we know he's unlikely to make it, doesn't bring out the point. We're almost 100% sure that the patient is not going to make it. In that situation, we still continue care because we are bound by ethical code to continue caring for someone, even if we know that they're unlikely to make a recovery or unlikely to gain maybe how they functioned before, we still continue. So you asked who determines, and my colleague said multiple factors. So many things go into how long someone stays in an ICU. What's the severity of the illness? Is it reversible? If it's extremely severe, expect a longer stay in the ICU. If, for example, you have been brought maybe just for observation after a significant operation, expect to be there maybe for 48 hours. If you have been brought there and you have maybe a debilitating disease that doesn't allow you to breathe on your own, you're going to be there for quite some time. And this also plays into why ICU beds are, should I say, on high demand, because they get occupied extremely quickly. On a daily basis, I get calls from different regions in the country, from Arua, from Jinja, from Masaka, always the same thing. Dr. Alvin, I have a patient. That's how the conversation starts. And then we have to go through everything. What's wrong with the patient? What illness is the patient suffering from? How severe is the patient? Sometimes I discourage the people who want to refer patients from transporting the patient, because in that mere transporting of a patient, you are actually exposing them to more risk. We're actually worsening their condition. But still, we have capacity. We do take up patients from around the country. One important one which we had previously was mothers. Mothers who had complications in childbirth. For example, mothers who lost a lot of blood and had damage to their kidneys. Previously, we used to receive a number of them, although the numbers have come down, which I think speaks, which I think is a good thing, although they are going to different places, which means capacity is being built up in different hospitals to receive critical patients. So yes, if a patient is in the ICU, expect different levels of different periods because they're all different. And they all have different illnesses, they all have different conditions, the reversibility is different, the duration which they're going to spend in the ICU is also going to be different.
Now I'd like you to speak to the fact that it's what people say, the lay people. There's certain times I think after the person has died, these normally outbursts come out where they think the person was long dead in ICU, but they kept the person there because they want the bill to go higher. The hospital is making money. I'm speaking what the lay people speak.
Oh, okay. Personally, in Chirudu Hospital, it's a government hospital. I don't think we can do that, to be sincere. I will not speak for the private facilities. I have never had that one. That's a new one to me. I think it's possible. It's actually a possibility. It can happen. But on my side, as a government health worker in Chirudu Hospital, that can never happen.
Well, that's a very interesting question. To be honest, I would think that if someone chooses the medical profession and we sign the Hippocratic Oath, one of the key things is first, do no harm. And then in the ethics codes, there are things like beneficence, justice, autonomy. And it would be very unethical and it would not be beneficial at all to keep someone alive, to run the bills up as someone is there. And perhaps this speaks to the importance of regular family conferences and telling them exactly what's on the ground. Because if the family knows exactly what's happening, they may not have such misconceptions. Yeah, but I think we have very good healthcare workers who follow ethics codes, and I don't think they're capable of that. I don't know. Yeah.
Okay, now we have this. Good morning. My name is Joel from Mengo, Kampala. Do we have any other option for patients in critical conditions other than ICU? Then this one goes, good morning, Madam and entire UBC fraternity. I'm Godwin Nabasa from Mpigi. I thank you for the good program. I'd like to thank Chirudu National Referral Hospital for the great work done, especially the ICU staff, for their great performance and medical management. I remember I had a patient who was critically ill and was admitted in their intensive care. We had lost hope as a patient's family, but they did a great job and our patient survived death by those great men that now I am watching. Long live Chirudu, long live Uganda, long live the government. Thanks.
That's a very good message. Like you said, the person is from Mpigi?
This one is from Mpigi.
Okay.
Mpigi, yes.
Thank you for appreciating our work. Thank you very much. To the first person who said, is there another option? Unfortunately, the critical care unit, or the ICU, is a step up in severity of illness. It's a step up in management of an illness. And as we've discussed through this entire show, it's a unit where you get constant monitoring, you get constant interventions if you do need. So if a person's illness is extremely severe, the only place where you can be stepped up to in a way that's adequate to you is the ICU. So I believe I think for that gentleman, he said if it's from Mengo,
yes.
You must understand that an ICU is a step up from the general wards, and in case the severity of an illness increases, an ICU is the right place to be.
Are there any challenges you face as a government entity in running ICU?
Yes, as in any institution, there are challenges that are faced in any institution. However, the most important thing is that there is always the impetus to make things better. By that I mean, for example, let's say by the time we started that unit in 2021, we had about 3 beds, and I remember I started with one of the very senior nurses in Chirudu, Sister Bender. We were only, it was myself and Sister Bender in 2021. And then we went and said, okay, we are starting the unit. 2 people can't run a unit, we need more people. And we presented the case to the administration. Within a short time, we were able to get 6 doctors and a number, I think 13 nurses. So in total, the unit is now about 20 people. So while the challenges are there, and I think every institution has any challenge, I think the most important thing is the interest to solve the challenges once they're brought up. So as clinicians and as the team, our role is, if we identify challenges, we flag them up and then we bring it. I think I mentioned to you, one of the earliest challenges we had was transferring patients, moving patients from level 6 to level 7 for dialysis. So people who needed their kidney to be cleaned, okay, you could say that, their blood to be cleaned, we moved them from level 6 to level 7. And that was a challenge, moving very sick patients. We presented it to the hospital saying, okay, you have a dialysis unit on level 7, we're on level 6. Why don't you just drop plumbing to us? And plumbing was done, and now the unit can actually have dialysis in the unit. So while challenges are there, they're everywhere, we always bring them up, and in due time, what can be sorted is sorted.
Yes.
Okay. Thank you so much for bringing such a topic and hosting such guests. They have greatly demystified a lot about ICU. This is Dr. Amos Kuduza from, he's a medical officer from Amicus Medical Center, Lweza, Wakiso District. Okay, then we have, hello, I am Kathy from Kampala. During COVID-19, I was in the ICU besides the COVID doctors and couldn't figure out what was wrong with me. So they curved my body inwards to take water from my back, lower back.
Okay.
Years later, my back has failed to heal. I feel pain in the lower back and I feel like fluids are in my thighs. Is this as a result of the procedure done in ICU? What is the solution?
Okay, thank you for that question. What she's trying to describe, I think, is a complication of a pneumonia, or it can be caused by a number of things. When people say they have water in their lungs or water in their chest, sometimes we actually do have fluid that lines our lungs, but the amount is what makes an ill person different. Situations come where the fluid that lines the inner cavity between the lungs and the chest increases. If it does increase, it causes you to have difficulty breathing. So once you have difficulty breathing, one of the ways to give you some relief, and also one of the ways to investigate what's causing you to have that water in the lungs, is to place a tube inside your chest. But before we do so, we must do some investigations. We must do some x-rays, we must do some CT scans, and we image your chest. Once we find that the water or fluid that has accumulated is significant enough to cause some distress, we do remove it. Firstly, we remove it to examine it. It could be due to a number of things. It could be cancerous, it could be due to liver failure, it could be due to a pneumonia as well, a severe pneumonia. So when you see doctors putting in tubes into people's backs or on the side of their body, trying to get out some fluid, it's one of two things. Either they're doing it therapeutically to give you some relief, because imagine your lungs being pushed up by some fluid. So when they remove the water, it's therapeutic. Secondly, they're trying to do something diagnostic, or trying to find out what's the cause of this. So when we take off the samples, we take them to the lab, take them to be looked at under a microscope. A number of our tests are run, and that fluid is able to give us more information which can help us to treat whatever ailment had caused that water to build up.
Because how now can Kathy be helped? Do they still need to get to a bigger hospital? Because, you know, ideally, as the lay person, we have a particular chain of when we talked about this earlier.
Yeah.
When we fall sick, certain times we're like, it's a headache, not knowing that the headache is a symptom of something. We'll first take our paracetamol, because I mean, it's often a counter drug I can easily access. When that fails, then the condition is like getting there and there, then others will resort to herbal. When the herbal fails, then we're like, there's that car clinic nearby, you know, and it's cheap.
Yeah.
Then we'll go to the car clinic. By the time we come to you,
Yeah,
it
so
is something different. So how can Kathy be helped?
yeah, so I'm very sorry for what Kathy is currently going through. I would really encourage her at least to go back to hospital and have another checkup. The good thing is that there are other places that are very specialized. For example, there is Makerere Lung Institute. So if there's still a problem with the lung, she can actually go to Makerere Lung Institute, where there are doctors who have specialized in management of everything lung. So that's what I would encourage them. Please go and seek medical care, health care, and see how you can be helped.
Okay. Now, thank you so much for the program, UBC and team. Chirudu National Referral, this is Dr. He says Dr. Sekankaye from PG. Any plan for government to expand the ICU space?
That's a very good question. I don't know, is there more? Or
Yes, there's still some more.
Go ahead.
Then, hello, I am Hilary from Arua. My mother was brought to hospital and diagnosis indicated liver at level 5, and the hospital told us the kidneys have a severe problem and they are unable to support us in this facility. What is your advice to handle this situation? I don't know which facility, possibly that is in Arua, I would like to assume.
Okay, I'll take the one from Dr. Senkai.
Yes.
Yes. Maybe some information maybe the public does not know. Chirudu National Referral Hospital has been at the forefront of dialysis. There are a number of sites which have been set up across the country in different regional referral hospitals of dialysis. Why I'm saying this is because last year we were able to go to these satellite dialysis centers. And in all of these satellite dialysis centers, we're able to see that each regional referral hospital has received equipment and has actually taken a step further to implement installing the equipment and starting the ICUs. So different regional referral hospitals are starting. They're picking up the mantle. A few have already begun. Others are just starting. Some are building the infrastructure. Some are expanding the infrastructure, because some hospitals maybe in the periphery of Uganda maybe had 1 or 2 ICU beds. Some are now being expanded. I will not speak to the exact numbers because I don't have them offhand, but I know ICU beds are slowly but surely increasing in the country. Yes.
Kathy, still,
yes.
Sorry, please.
Just to add on that, while the ICU beds are also increasing, there is also a drive to train more people in intensive care. So all that is happening. So hopefully in the next couple of months or years, things may be better.
Kathy is still back from Kampala, and she says the fluid was taken from the lower back and not the chest, and the pain is in the lower back and the fluid is in the thighs. Wow.
Well, it sounds like challenging situation, and that's why I would still really encourage her to seek medical advice. One of the reasons why I'm saying that is that with these symptoms that she has told us, there are multiple things that could be happening. Number one, I would need to examine her to see exactly what's happening. So if you say lower back, it is interesting that the biggest part of the lung is actually in the back. So I don't know if it's still part of the lung or just the muscle. So she needs to go see a medical healthcare professional, and she's fully examined, and after being examined, they can determine the right tests to do. So yeah, that's what I would encourage her to do.
Okay, I am Gift from Chebando. I would love to know, if I don't have the money, like you mentioned, 2 million to support my relative in the ICU, will the hospital just let them die, or they will look for another way out?
Okay, thank you for that. As I said earlier, that 2 million per day or those exorbitant amounts are mostly in the private facilities. So I think she's talking to the effect of a private hospital. In the private setting, I will not speak for them, but I assume they are unable to help you if you're unable to pay the bills. So even if you're admitted, a point will come when you're unable to pay the bills, because an ICU bed in the private setting is really quite expensive. They're offering a critical care, but it's really expensive. Unlike us in a government setting, who are subsidized greatly to a very large extent by the government, we are subsidized in a number of things, in terms of drugs, in terms of equipment. We're able to give the service at a lower cost. So I don't agree with him saying that should they just let the person die? No. The person can always be taken to the different government hospitals, which in case there's one close to him, or in case there's far, he can arrange a transfer to our ICUs. And there are a number of ICUs which are available. For example, Mulago has a very big ICU, Chirudo has a big ICU, the Women's Hospital has a big ICU, Bara has an ICU, so there's capacity being built. I cannot say that how we were 20 years ago or 10 years ago is how we are now.
Yeah, true.
There's a definite improvement in healthcare in this country. I think that goes to give kudos to the government and the Ministry of Health. I feel they're doing a great job. What may be bothersome is maybe sometimes they do so good a job that people
don't get to know.
People don't get to know. And also, people, the population is quite big. Sometimes we're overwhelmed. We get very many numbers of, a large number of patients who come in. Just as I said, I receive phone calls almost on a daily basis. Right now, as we're speaking, I'm pretty sure there are 5 people in Chirudo Hospital right now who need an HTU or an ICU who were not there yesterday. What do? If we're unable to take them up to our ICU, we find ways, we innovate, and see how we can help them best wherever they are. There's a lot of multidisciplinary teamwork that goes on in the hospital. So whenever we have a patient, we are more optimistic than pessimistic or negative. We try our level best to help patients wherever they are and to the best of our capacity.
Okay. Now to you, Kathy, who is talking still about your complication, sorry about that, but like you have been guided and advised by the doctors, kindly go to the nearest hospital or back to the hospital where you were treated and let them be able to do further investigations to help you overcome that challenge. It is a pity that you still have that. I'd like us to take a very short break, and when we do come back, we're still continuing with our topic of discussion.
Chirudo National Referral Hospital, and this is our ICU. Our ICU was developed and started in 2021 in response to the COVID-19 epidemic, and we started originally with 3 beds. We started as a 3-bed ICU, but as we could not fulfill the needs for the entire hospital and for the country, the ICU was expanded to accommodate approximately 9 beds. We usually manage patients who have respiratory failure. That's patients who are unable to breathe on their own. We're able to place them on our machines known as the ventilators, and we're able to give them support. We're also able to give critical patients critical care in terms of advanced life support and such. We also receive patients from around the country who have a number of issues such as kidney issues, who we are able to help with dialysis and other support as well. Currently we have a capacity of 9 beds. We do try to improve, and we do try to build our capacity to have more patients.
Janani Luwum Day is a public holiday in Uganda, annually celebrated on 16th February. It marks the day in 1977 when former Archbishop of the Church of Uganda was martyred for his courageous stand against human rights abuses during Idi Amin's regime. The 49th commemoration of St. Janani Luwum Day will take place under the theme Anchored in Christ for Stability, Peace and Unity in Muchwini Sub-County, Kitgum District. Don't miss the live event on Monday, 16 February 2026 on UBC TV.
Exercise can't be sustained. Eating can't be stopped. It's even harder to lose weight. Come and give it a try. Genshikang L-carnitine chromium capsules, plant extract, scientific ratio, take 3 capsules each time. The active ingredient accelerates fat burning, eat twice a day, don't take a detour. Weight loss starts now. Genshikang L-carnitine with chromium capsules helps you stay in shape. Please follow medical advice when taking this product. For more information, visit our website www.hgo.com or call 0800 335555.
Pick of the day on UBC.
Every Wednesday, 10 p.m. on your public broadcaster.
was brought to you by
I'll call you every day, yeah, yo, baby, don't know.
You can now get all the Chibuzi out with MTN voice bundles. Call all networks. Kubei Dondoro. Buy a 25-minute voice bundle for only 1,000. Or buy any daily voice bundle of your choice. Dial *100 *21 hash and select daily, or use the My MTN app. When we talk together, we are unstoppable.
Welcome to Chirudu National Referral Hospital, and this is our ICU. Our ICU was developed and started in 2021 in response to the COVID-19 epidemic, and we started originally with 3 beds. We started as a 3-bed ICU, but as we could not fulfill the needs for the entire hospital and for the country, the ICU was expanded to accommodate approximately 9 beds. We usually manage patients who have respiratory failure. That's patients who are unable to breathe on their own. We're able to place them on our machines known as the ventilators, and we're able to give them support. We're also able to give critical patients critical care in terms of advanced life support and such. We also receive patients from around the country who have a number of issues such as kidney issues, who we are able to help with dialysis and other support as well. Currently we have a capacity of 9 beds. We do try to improve, and we do try to build our capacity to have more patients.
Commercial break. We're still talking about ICU, what really happens behind closed doors. And of course, Dr. Alvin and Dr. Preacher here taking us through and continue with our discussion. Now, I am Senyondo from Wakiso. Thanks to the 2 gentlemen for the great service and the entire workforce of Chirudu. For sure, sometimes the number of patients overwhelms them. Okay. I am Hillary from Arua. She still, no, this is Hillary did. I haven't, Hillary is saying he hasn't yet had feedback about his inquiry, where he says that their mother was brought to the hospital and diagnosed and indicated liver in level 5, and the hospital told them that the kidneys had a severe problem and they are unable to support them in this facility. How should they handle? Because I think he's from Arua. Possibly they have failed to support them, or they have failed to get the necessary support in Arua where they are.
Okay. First of all, thank you for that question, and I'm very sorry for what you're going through. If I could start by approaching that question, the organs we have in the body, they speak to each other. If one organ is failing, it can cause another organ to fail. For example, if the liver is failing, it is known that the liver can actually also cause the kidneys to fail. So what I would encourage him is to go to a hospital where they can support his kidneys. I think maybe the nearest one might be Lira, if I'm not wrong, but I think they can enter into the referral system and they seek a hospital where they can get the support that they need and the organ support, especially for the kidneys. They can do that.
This
I think also in Lacho, they also do it. Also in Lacho.
Maybe I can supplement on this. It's a very important point which I wanted to bring out. We need to try to prevent people getting complications or getting illnesses. I sometimes feel, of the patients I've received in the ICU over the past years, I've seen the illnesses have been preventable. Our kidneys filter blood on a 24-hour basis, and they are damaged by a number of things. Yes, they're damaged by lifestyle, but they're damaged by avoidable things in our lifestyles. I feel if we paid more attention to our health as individuals, because I feel every human being or every citizen of the country is part of the health sector. Health starts with you. Health starts with you as the individual. You need to prevent these non-communicable diseases, because we have the ability, we have the information, we have the knowledge. For example, we have received a number of complications from diabetes. Diabetes damages the kidneys, and diabetes has very severe complications. A person who has diabetes initially may not feel much. They may just feel thirsty, they may just feel they urinate a lot, sometimes feel weak, but they may not seek medical attention. You find that person continuously spends a long time without ever going to see a health worker or a doctor. Some even go as far as resorting to herbal concoctions. These herbal concoctions also damage the kidney. As I said, the kidney filters our blood. So you're giving the kidney more work to filter out toxic things to your liver, to your kidneys, as well as toxic to the rest of your body organs. Other things like hypertension, if we're able to go to a clinic or to a hospital and measure our pressure maybe once a month, we would be able to identify if we have hypertension early on. Because in the ICU, we get complications of the hypertension as well. People who have strokes, that's when an area of your brain maybe doesn't receive blood, or maybe a blood vessel in the brain bursts. So all these are complications of, I feel, preventable illnesses. I feel we should spend more time in prevention, and we should take it upon ourselves as individuals. Talk to your relatives. If you have a mother, or if you have a father, or if you have a relative, and you just out of the blue just say, let's go for a medical checkup, maybe once a year, you can discover an illness in its initial stages. An illness is best discovered in its initial stages. If you're to discover an illness maybe when you've had it for 5 years, compared to when you've had it for 1 year, you're more likely to have a better chance of recovery if you found it earlier. So I think this speaks more to us focusing on prevention. Let us take time off, go for a medical checkup, do routine labs, because as we reach certain people who are in certain age groups, maybe above 50, they're more prone to getting certain illnesses. So our elderly population needs to be screened and checked on more often. Even the younger population, because we're seeing diseases which we found in the older population now so much more common in the middle-aged and younger population. Initially, when we had started working, the ICU average age of admission was between 50 to 65. Currently, we're seeing people between 25 and 40 coming with illnesses which you would ordinarily have expected to find in the elder population. So I think we need to spend more time and maybe be more empowered to go for medical checkups, take our health more seriously. We shouldn't always rely on blaming the government or blaming health workers. Health starts with us as the individuals. Let's have more interest in our own health. Let's take intentional choices with our lifestyles to keep ourselves clean, to keep ourselves healthy. I think that's an important point which everyone at home should take on.
What about the fact that people tend to get so comfortable and someone will tell you, I've not had malaria for the last 10 years. I've not had this for as long as you're sailing well. It's like saying the car is moving. As long as I fuel, that is the food. I don't see why I should go and maybe check the fuel pump, do this, the other. What really do you think is the problem? Because we have poor health-seeking habits. We only think you have to go to the hospital for as long as you're feeling unwell.
Yes, thank you for that question, and my colleague for pointing that out. Definitely, prevention is better than cure. And especially in terms, if you look at it in terms of the intensive care unit stay of a patient, there's something we normally refer to as the pre-morbid state, or let's say the physiological reserve. So let me explain it this way. Imagine you have a glass of water, and that glass of water is your health, okay? So let's say a critical illness comes and it shakes the glass of water. If that glass of water was full, it can reduce maybe to 3/4. So if you come into the intensive care unit and you're quite ill, but your glass is, or your health is 3/4 your baseline, then it's easy for us to bring you up back to full by supporting you. But if you come in and your pre-morbid state or your physiological reserve, let's say it's this glass of water and it's already 1/4, and critical illness shakes the glass and pours, you literally almost have nothing. So, and that's where the prevention aspect comes in. If you have regular checkups, your blood pressure and all, you will always try to maintain your health. In this case, I explained it's a glass of water. You'll always try to maintain your health to be at least on the upper limit, so that when critical illness comes, because anybody is a candidate to be critically ill, anybody. When the critical illness comes, it finds your physiological reserve, that glass of water. It finds it at least 3/4 or even full. Therefore, even if the critical illness comes and shakes it, some will remain there, and therefore we shall be able to support you in a very good way. So prevention, by having regular health checkups, we cannot overstate it. It's extremely important. Prevention is better than cure.
Yeah, true. Okay, I am Carol from Entebbe. My mother is having blood pressure, but whenever she takes her medication, she goes for a short call like 5 to 6 times at night. What could be the cause of that? She takes the medicine before bedtime. Then this is, I am Stephen from Serere. Dear doctors, I've been experiencing recurring mouth wounds on my tongue and gums for over 5 years. Despite treatments, every time one heals, another appears. I've tried various clinics and referral hospitals. Now I am having severe back headaches. I would appreciate your expert advice. What could be causing these recurring wounds? Should I see a specialist with an oral medicine expert? Any further tests would you recommend?
I'll take the question from Carol. Thank you, Carol, for that question. Sorry about your mother's illness. Drugs have side effects. However, the side effects can also mimic another illness. Because urinating a lot can be a symptom of something else altogether. So in Carol's case, I would encourage her to probably go to a professional health worker, preferably a physician, an internal medicine physician, and assess or review her drugs. Maybe some of the drugs are causing her to urinate excessively or to urinate at night, because some drugs do that. They actually work by making you make more urine. But also it may be a symptom of something underlying. Maybe she has another issue with her kidneys, or maybe she has another illness that's causing her to urinate a bit more. So for Carol, I would say take your mom to a physician, let her be reassessed, because you can always get new illnesses. Yeah.
Okay. Thank you. I will attempt the question from the second gentleman about the recurrent ulcers in the mouth. They come and go, and now he has back pain. I can imagine it must be very uncomfortable. Well, there are multiple causes of this. Perhaps I would encourage him to see someone called a rheumatologist. Okay, so a rheumatologist is someone who specializes in things about connective tissues. So, for example, you can see there are things attached. If you have joints, there are things attached to them and everything. So a rheumatologist might help this gentleman from Lira because what he's describing could be one of the many diseases that can fall under rheumatological conditions. There's something called Behçet's disease. There's something called aphthous ulcers. They could all describe this. So I would really encourage him. He could start by seeing a physician, an internal medicine specialist. And after seeing an internal medicine specialist, they could actually refer him to a rheumatologist. That is someone who is specialized in connective tissue disorders.
Okay, he's in Serere. Do you think, anyway, does he need to come to Kampala? Because at certain times, some of those specialties are very rare, that you might find the hub is within here. Yes.
I think there are very good internal medicine physicians all around the country. So I would encourage him to first contact his nearest internal medicine physician in the area where he lives, and then from there they'll be able to guide him where to go next.
Okay. Now I'd like to ask, after somebody with the survival chance of ICU, what is it like for some of those who've walked out? Do they lead a normal life? Because now we're looking at a person like Kathy, who is complaining about some other issues that she has incurred after she stepped out of there. Do they lead a normal life, back to normal, 100%? Right.
Thank you for that question, Sophia. It's a very good question. Firstly, the illness that takes you to the ICU, it affects you differently. There's an illness that can take you which has a permanent effect. For example, an illness that takes you like a stroke, where you have a disability, maybe one side of your body is not functional anymore, but you're taken to the ICU because of maybe a pneumonia or a severe lung infection. Let's say you survive the lung infection and you get out of the ICU. The stroke which you had prior to entering the ICU may not improve or may take some time to recover. However, there are some reversible illnesses that bring patients to the ICU. For example, there's what we call acute kidney damage. And we recently had a patient, a young boy, from, or maybe I'll not say where he came from, but he had taken some toxic substance. I think he was stressed and maybe was not happy with his life. So he took something to damage his, himself. In the process of doing that, his kidneys got damaged. However, we were lucky that through the referral system, he was able to get to us on time with the physiological reserve of above 3/4, as my colleague had said. We were able to give him support, that is, dialyze him, wash his blood. We're able to support his blood pressure, that is, giving him medicine that can keep the heart pumping. And through that, we bought him time for his kidneys to heal. He is very happy right now, currently discharged, able to walk, able to talk. So different patients have different outcomes once they're discharged. Some have continuous effects of the illness that brought them. Some recover 100%, and some maybe have some minor deficits. Every patient is different.
Yeah. So to add on that, as my colleague has said, indeed, life after intensive care unit is very different. In the first year, after being admitted for critical illness, in the first year, unfortunately, the chances of death are higher than in the general population because you are very critically ill. And there's some complications that can happen as a result of critical illness. There's something called critical illness associated myopathy or critical illness associated weakness. Essentially, the critical illness has made your body struggle and undergone a lot of stress. So you come out of the intensive care unit and you're weak. Now imagine, if you're weak in your bodies, imagine what your brain has undergone. So even people after intensive care unit stay, their mental state in terms of their cognition, cognition I mean, for example, right now you can do simple arithmetic, 3 times 3 etc. The brain is also affected and it takes time to recover. But then importantly, some people even end up to the extreme, and this is now in the area of our colleagues in the psychiatry department. Some people end up having post-traumatic stress disorder. So think about it, you are in an intensive care unit, you're given these drugs to keep you calm, but these drugs affect your brain, and you end up with a confusional state we call delirium. And you may not remember everything. Now you're out of the unit 6 months later and you're having these flashbacks, and they can be quite intense. So depending on what took you there, different people have different complications after intensive care unit stay. However, the first year after intensive care unit stay, the chances of death are higher for the people who have been admitted in the intensive care unit compared to the others, because you had a significant life-threatening illness. And therefore, someone might walk away with battle scars and not completely clean, but others completely. So it depends with what took you there.
So when they're out, how should they conduct themselves? Because I can imagine you're vulnerable, yeah?
Yeah.
You're prone to infections,
yes,
exposure, environment. How should they live their lives?
And that comes, that's a very good question. And it comes to the process of referral to the intensive care unit. So let's say someone has a severe infection and they were in the infectious diseases unit ward. The ward level care was not enough and they had to be transitioned to the intensive care unit. Now, after intensive care unit, we don't send you immediately to the ward. We first send you to the high dependency unit, and once we are comfortable that you can actually survive on your own with the minimal interventions, we send you back to the ward. So usually it is the parent ward or the parent team that originally sent him or her to the unit that does the follow-ups. But the good thing, some intensive care units also have follow-up clinics in terms of, yes, we discharged you from the intensive care unit, you can come back after a month or so, we just see how you are and we coordinate. And that's where the referral process is important. If you came in from the renal unit, the unit that deals with kidney problems, once we discharge you, we discharge you back to them, and then they can follow you up. So the referral process is extremely important because it helps with the continuity of care even after intensive care case has stopped. Yeah.
Okay, that's nice. Hello, doctors. Thank you for the show. I am Patricia from Bukedea. I was diagnosed with hepatitis B, and my last viral load result was 2010. But I have 2010, is it millimoles? But I have severe waist, back, and stomach aches. What should I do, please?
Thank you. She said she's from
Bukedea.
Bukedea. Sorry
Yes,
about your
Bukedea.
illness. Hepatitis is an illness that's actually with us. I'm not sure of the exact numbers, but it's quite prevalent. And it's an illness that's spread through exchange of fluids, maybe through different methods. So, however, there is treatment for it, but the point at which someone is started on treatment for hepatitis has to follow a certain criteria, based on labs, based on age, based on a number of things. So in her case, I assume since she was diagnosed, she's in touch with a health worker and probably a physician or a medical doctor who is able to guide her on the medication she's on. She didn't specify if she has started the medication, but those other X and other symptoms she was describing, I would encourage her to come to our hospital, Chirudo Hospital, on Wednesday. We have a dedicated hepatitis B clinic. We have a number of specialists there who are able to assess her and maybe guide her much better. And it is all free of charge.
Okay. Hello, I am John Lucky Mwesije here in Chenjojo. I wanted to know, how do you prioritize patients when if the ICU is full? How do you handle patients who suddenly deteriorate or experience a life-threatening complication? Otherwise, thank you for the show. Oh, before I forget, Carol also said thank you for the guidance.
Oh, okay.
Okay.
Yeah, thank you for that question from the gentleman in Chenjojo. The question is, how do we
prioritize how do you prioritize patients if the ICU is full?
Yes.
Yeah?
Yes.
And then also, how do you handle patients who suddenly deteriorate or experience a life-threatening complication?
Okay, so those are two questions, and I'll attempt to answer them. So the first question is, to be honest, I need to be very honest and clear with everybody, is that there will never be enough ICU space. I recently finished fellowship training in Cambridge University Hospital, and in that hospital, it's a 1,000-bed hospital, and the ICU space is about 60 beds. Every day, there are questions. Can we bring a patient? Can we bring a patient? So ICU space will never be enough the world over. That's the truth. Now, choosing patients between A and B who would benefit from ICU. Now, this comes into a point called triage. So triage, essentially, you are looking, okay, what are the life-threatening complications this person has, and how fast can we resolve them? So let's say you have two patients who would be possible, they would possibly benefit from the intensive care unit. And let's say patient A, the problem is oxygen. He or she needs oxygen, the saturation level. Normally, as we sit here, our saturation level is at least 94%. So let's say the saturation level is 76%. And then you have patient B, who might need ICU, but the saturation level is, let's say, 92% or 88%. You will give priority to the sicker patient than the other. And that's the very important concept of triage. During the COVID-19 pandemic, which ravaged the whole world, the concept of triage came in very importantly. And as you're triaging a patient, number one, you want to know what they're suffering from, but importantly, as I previously mentioned, the physiologic reserve. Okay? So let's say in an extreme situation, you have, in a very extreme situation, and these are very uncomfortable situations that you have. Let's say you have a 15-year-old with severe malaria. The kidneys are shut down, severe malaria. And then on the extreme end, let's say you have a 70-year-old with severe difficulty in breathing, and you have one ICU space.
What do you do?
What do you do? And the concept of physiological reserve comes in, and the concept of frailty. So frailty is also very important. So the whole idea is that the more frail someone is before intensive care unit admission, the chances of recovery are lower. So the concept of triage comes in, and unfortunately, healthcare workers in resource-limited setting, all of us, we face that question every day. Who would benefit the most from this space that you have, from the resources that you have? It's not an easy decision. It's not an easy experience. But what you say, for example, in such a situation, I would take the 15-year-old, take them to the ICU, do everything. For the 70-year-old, I would bring the care to him or her where they are. If it means bringing in a machine just to give them oxygen without putting in a tube, I'll do that. So as we're getting space, I would start treatment for both of them, but at different spaces. So the issue of triage is what we face every single day, and we just have to see how best to allocate the resources. So I'll treat both of them, but at different places.
Okay. Would you like to attempt the second one?
Second
Oh, yes.
modality.
I think the question was, what do we do in case there is a sudden deterioration or sudden life-threatening event?
Yes.
So the ICU is a very unique unit. It has a number of things in it. It has equipment that which is able to, for example, restart a heart. Let's say you're in the ICU and your heart stops. In that same moment, we're able to identify that your heart has stopped. Not even a minute can go by. Within that same minute, we're able to attach you to a machine that is able to restart your heart. In that moment, there is a procedure we call CPR. CPR is when we try to restart your heart by, maybe if you've been seeing some television shows, or maybe you've been to the hospital, you've seen where medical workers start pressing down on someone's heart and trying to get them back. In the ICU, it's a bit more specialized because we have machines which are able to send some electrical impulses through the heart and restart it. Then there are situations, as Dr. Pitch had said, regarding the breathing system. If you're in the ICU and we notice that your oxygen levels aren't adequate, we are able to quite quickly intervene and place you on a machine which is able to deliver oxygen at a level that can benefit you. Also, there are situations where we find your kidneys are not working completely. You're unable to make urine, or the urine you're making is not what it's supposed to be. In that very instant, we have a machine within our ICU called the dialysis machine. Once we notice this, we do not waste any time. We hook you up to the machine and wash your blood. Though I must remind you, all this comes back to the severity of the illness. How sick was the person before coming? Because not all the time when we hook you up to these machines is a guarantee that we can save you. But it's a step in the right direction. Yeah.
Then maybe you might need to tell them that if somebody starts on dialysis, is it a continuous process until forever, or after, there's some bit of them being stable, then they can be able to pull off on their own?
Thank you for this question. And as I had said earlier, prevention is very important. We have an increasing prevalence of people who have kidney issues, chronic kidney disease. And chronic kidney disease, or even acute kidney disease, is brought about by a number of things. As I said earlier, we should focus on the prevention. We should focus on preventing hypertension, diabetes, or managing it in such a way that it doesn't cause damage. People who are put on dialysis is for a number of reasons. One, your kidneys are not working, but it's a reversible cause. For example, the mothers who are giving birth, they have some situations where they lose a lot of blood and the kidney is not receiving blood, and in that instance, the kidney kind of shuts down. Those mothers, when taken to a dialysis unit, it's actually an emergency. We need to dialyze them or filter their blood by placing them on the dialysis machine. This gives their kidneys a chance to heal. So those who have a reversible cause of kidney damage, once placed on dialysis and are able to recover, will not need to continue with dialysis after the recovery. However, there are those who have experienced unreversible or severe kidney damage. Kidney damage due to things like hypertension, diabetes, and other diseases where the damage to the kidney is not reversible. Such people, unfortunately, have to be on dialysis for the rest of their lives. However, there are options now with the kidney transplants coming on locally within Uganda. You'll occasionally see people when they tell you there's a fundraising for someone to go to India for a kidney. Those are people who really, their kidneys have stopped working and they need to replace them or be on consistent dialysis sessions. Remember, your kidney is working 24 hours a day. Imagine it stops working completely and you need it to work. So at Chirudu, we have a very big dialysis unit. We do over 60 dialysis sessions a day. What we try to have for our patients is each patient who is on chronic dialysis, these are people who actually need to come to receive their kidney from Chirudu, for example. They need to come at least 3 times a week. However, it would be good if they could get it daily, but it's not possible because of the numbers. Ideally, what we should be targeting in the future, I think, is to be able to have more kidney transplant capacity, and I think it's being done in Mulago. I think over the last 2 years, they've had a number of kidney transplant operations, and they've actually been successful. So I think in the future, I would still advise, let's stick to prevention. Let's not wait for our kidneys to be damaged. Let's not wait for our liver to be damaged. Let's try to take some measures and try to protect our kidneys. Because you have 2 kidneys, but trust me, once they get damaged, you have none. You really don't have anything. And you have no replacement which you can use on you. So I think the chronic people, please come for dialysis sessions. And let's hope that our capacity to do organ transplants is built. People are trained, because it's specialized, extremely specialized procedure when we have a kidney transplant being done. But the capacity, I'm fully aware, is being built, and I think in the coming years, more people will be able to benefit from organ transplants, especially those with kidney ailments.
Okay, that's good. Okay, thanks for the program. I'm under the treatment of TB of the spine in my 3rd month, and I was told that the treatment will run for a whole year. Is that correct? This is Samuel. This is Samuel Mogisha from Chenjojo district. Then you have greetings from Edith from Masaka. Thanks for serving Uganda doctors. I would like to get advice from you. I have a sharp pain in my right lumbar region, which comes and goes for some days. But when I conceived, the pain worsened. I went for scan, but nothing was diagnosed. What can I do?
I think let me take the question for the gentleman with TB. Sorry for that affliction. TB in the past was considered somehow a death sentence. This was over 50 years ago. It was previously known as consumption, because the TB would actually literally consume your body. But with time, people realized what was actually causing the illness. And anyone can get TB. Anyone is at risk. Anyone is a candidate to get TB. So when you get TB of the spine, it's a severe type of TB because it's actually within the bone. TB can affect anything. It can affect your lungs. That's a common area. People will be coughing. It can affect your skin. It can affect your adrenal glands, your endocrine glands. So once you have it in the spine, the treatment duration is a bit longer. It lasts a bit more than a year. The simple TB, which is an infection known as pulmonary TB, is an infection of the lungs. And we receive, once you see someone who has been coughing and has been repeatedly coughing, a productive cough for over 2 weeks, take that person to a health facility. Let them get checked. Let them have that sputum or what they cough out. Let it be checked, because it's a public health hazard. Because you can be in a taxi, you're coughing, someone inhales what you're coughing out. You can be at work, you're coughing, someone inhales it. But thankfully, the health sector is extremely robust and very adapted to TB management. Almost every division, I think, in the country has a place where you can go and be tested for TB. So once you're tested, they initiate you on medicine. This medicine is called a regimen of different treatments. For TB of the spine, it takes much longer because the drugs have to enter the actual bone itself, and penetration of the bone is much more complicated than penetration of maybe the lungs, so they put you in a longer duration. I think for him, he should continue taking his medication, but he should not fret. TB is extremely survivable, and you can continue having a productive life as long as you take the medication the way you're supposed to. But for the general public, if you ever see people who have prolonged coughs, maybe they are sweating at night, they are losing weight, please don't leave them. Please take them to a health facility, let them get checked out, because as I said, health is all of us, not just the health sector.
Okay.
Yes.
Would you like to respond to Edith from Masaka, who has that severe sharp pain in her right lumbar region? And it's been going on for days, but when she conceived, the pain worsened. Much as she's gone for scans, there is nothing that is pretty much showing what it could be.
Yeah, thank you for that question. I'm very sorry for what you're going through. The pain on the right lumbar spine worsened with conceiving, with conception. There are many causes that could have. There are many possible causes of such a pain, and again, I would encourage her to go see a doctor, a healthcare specialist, so that she's fully examined. This is the reason why I'm saying that. So the lumbar spine, around the lumbar spine, so basically at the back, and she has pain around there. So I'm not sure if it is right at the bone or on the side. The reason why I'm saying that is that if someone has problems, let's say you have stones in your kidneys, pain would go to the back. Let's say you have on the right side, let's say your liver is big, hepatomegaly, some pain might go to the back. Let's say one of your discs of your bones is not working well, a pain might be there. So I would really encourage Edith to go seek healthcare consultation. She sees a healthcare professional, she's fully examined and investigated, and then we can know what she's suffering from and she can get help.
Okay. A round of applause to this very educational, healthy program. A quick one, please. What are the early symptoms for both kidney and liver failure and the immediate measures? Then, UBC, this is Arayo from Amuru. My dad is 60 years, a known DMA patient. He started his shots in May 2025, but the concern now is we have failed to achieve normal ranges in this. But generally, he's been fine according to his vitals. I don't know what DMM is.
Diabetes.
Okay. Then this is from Wakiso, and this is Bate. My brother has been suffering from osteoarthritis for 2 years, and I took him to many hospitals, and the problems continued as if the doctors added to the problem. I'm sorry, I have to laugh. I'm tired of this, please. What should my brother do so that he can overcome the challenges? Talk about the causes and solutions to the problem. That we might have a special edition, talk about the causes and the solutions. But I know, I'm sorry, Bate, for laughing, but I feel your frustration. There is no way the doctors can increase to the cause of that. So I don't know who would like to take a response to which one?
I'll respond to the person who has a mother with diabetes.
Yes.
Diabetes is manageable. However, you need to pay special attention to it. And the earlier you discover that you do have diabetes, the better your chances are of having a better life. I think she said that did she say the sugars are not in range even if she's on treatment?
I think so.
Yeah. So there are a number of different modalities to treating diabetes. And if you're on chronic care, that is, you're not admitted, you're at home, a number of things should come to your mind. Firstly, how is the diet? A number of foods we eat, especially being a tropical African country, we have extremely starchy foods. And starchy foods have very high glycemic indexes. These are foods which have very high levels of glucose. So for a diabetic patient, they need to be extremely careful with what they eat. They may be on medication, but the medication is not sufficient. They may be getting insulin injections, but the insulin they're getting injected with is not adequate to lower the blood glucose levels to a level which is recommended. Also, they could be having other illnesses as well, because there are certain other illnesses that raise the blood sugars. So in her case, I would say, please go out to an internal medicine physician, take your mother there, let them have, at least every 3 months, let them have a medical checkup where they check your blood sugars, where they check your kidneys, and where they have a look at your general health. And I think that way, she can have better cover of her blood sugars.
Or even the medicines changed.
Even the medicines changed. There are many new, thankfully, science and technology have really progressed. Compared to 20 years ago, there are very many new drugs, and they're doing wonders. There are a lot of drugs which have been introduced for diabetes. That's why I say diabetes is extremely manageable, and these complications are very controllable, because there are new drugs out there which people maybe in the past didn't have access to. So she should have an opportunity to meet up with the internal medicine physician and they can guide them better on which drugs to use. I always say, don't self-medicate. As much as they're new drugs, these drugs do have side effects. And the side effects, you may not know what they are. For example, I've seen people using the new drugs for weight loss, Ozempic and so forth. Ozempic is a treatment for diabetes. Maybe you did not know this. But Ozempic is a diabetes treatment drug. So people use it for weight loss, but also there's a complication that comes out of it where you have damage to the pancreas. So don't self-medicate is my message to everyone out there. Take an opportunity to take time, visit the doctor, spend some time at least once every 3 months, especially if you have a chronic illness. Take some time. I'm pretty sure she can get a better care if she does it this way.
Okay.
Yeah.
Can you,
Yes, I'll attempt to answer for Bate. I'm sorry you feel that the doctors are worsening the problem. So you have said that your brother has osteoarthritis. Yes, osteoarthritis, it's an important medical condition, and it can actually be quite debilitating. By debilitating, I mean it can hinder normal life because you have constant pain in the joints. I would really encourage him to go see a rheumatologist. So basically, a rheumatologist is a specialist in things concerning connective tissues and joints. So I would really encourage him to see a rheumatologist. A rheumatologist will be able to help the brother.
Okay, then
the first question.
There was Paul from Boyogere was asking about, please, what are the early signs and symptoms for kidney failure and liver, and what are the immediate measures? There are still many questions flocking in, so I'd beg for you to give it a quick response.
Well, for kidneys, what usually happens is it can be twofold. It can be depending on the cause. So some instances, you can see symptoms when it's even late on. For example, puffy face, puffy, swollen lower limbs, that is your legs become swollen, your face becomes swollen, you start having a kind of skin that is occasionally having some kind of white discoloration. You occasionally have fatigue, shortness of breath sometimes. So the symptoms or signs come from what the kidney is doing. The kidney is trying to remove water. So if you see yourself becoming swollen, puffy face, that should be an indication for you to get checked out. For the liver is more of a detoxifier, similar to the kidneys, but it does a number of other things by making a number of proteins and making a number of hormones that do different things. So some things may be non-specific, but for the liver specifically, you could get some situations where your skin changes color, your eyes change color, what we know as jaundice, a yellow discoloration. That's a good indication of liver failure. Also swelling of your legs, generalized weakness, feeling of malaise, feeling generally ill. Those can be early signs of someone who has liver illness or kidney illness.
Okay.
Okay.
Doctors, thank you for the immense work you do. I'm having very swollen legs with pain. The radiographer carried out a Doppler scan investigation, but nothing was found wrong. Currently, I'm having very much lower back pain. What can I do? Okay. Then, hi, thanks for the work. I appreciate. I am Ouma Wilson from Busia. My mother is feeling a lot of pain in the pelvic, and she's using a stick to walk. I request for help. Then this one, let's take this third one. So we have quick responses to them. Good morning, doctors. My mother is HIV positive and she keeps losing blood. Also, she complains of sometimes seeing nothing clearly. That is a blurry vision.
Okay.
This could be because of, could this be because of the HIV drugs, or there are other underlying situations? This one is from Arua.
Okay.
Okay. Yeah. I'll try attempt the question from Arua about the person whose mother has HIV. So it is good that actually your mother is on treatment. That's very good. It's really, I would encourage you to encourage your mom to go to the hospital where they check viral load and they ensure that she is taking her medication well. Concerning the loss of blood and the vision not being very clear, there are multiple things that can do that. If someone has HIV, there is a higher risk of non-communicable diseases such as diabetes, and that can affect the eyes. So as she goes for a general checkup, I would really encourage you to take your mom also for general checkup for the eyes. Okay, it's very important. And also to have their blood checked up. Remember, HIV is a disease that affects everything in the body, from the blood cells to the brain to everything. It can also affect the eyes. But the good thing, as you have said, she's already on medication, so that's a good thing. Previously, before antiretrovirals were common or people were taking medications, there were certain complications of the eye, viral complications of the eye in people with HIV, and that would cause blurring of vision. But since she's on medication, that's very good. Some medications have complications, and there's a high risk of non-communicable diseases such as diabetes. So I would really encourage you to take your mom for a full health checkup, head to toe. They will also get to find out why the blood is actually low.
Okay, I'll take the question from the gentleman, I think a lady who said her feet are swollen and she did a Doppler scan.
Yes.
A Doppler scan is done to assess the blood vessels, the patency. Are they maybe narrowing, or are they blocked? So sometimes people get swellings in their legs due to this, what we call venous insufficiency, and it can cause you to have things like clots as well. But in her case, she said both of them were swollen. I would advise her to, once again, to come to, I don't know where she is, but if she was in Kampala, I would say, please come to Chirudo Hospital. We have all the specialists available, and we're able to assess what really caused both legs to swell. A Doppler scan may not be sufficient to ascertain what was the cause. Maybe that's why the Doppler didn't find anything. She could be having issues with her liver as well. She could be having issues with her kidneys as well. So I would say you need an extensive workup to really find out why your legs are swollen.
Now then, there's this one. Kudos for the program. I had a friend I engaged to constantly do exercise with me daily. After 2.5 months of consistent road works, his diabetes went to normal. It's now coming to a year plus. Each time he checks, his diabetes is normal. He's discontinued medication as well. How is exercise a magic bullet for diabetes relief? This is Patrick from Arua.
Okay, Patrick, this is a very important point you have brought. Thank you for that. Diabetes is a disease that grows. So once it starts in your body, it grows. However, you have different points at which you can actually limit it. It's a disease of lifestyle in most cases. However, there are other types of diabetes which come not as a cause of lifestyle, but most of the ones which come as a cause of lifestyle, we as medical workers and doctors, we encourage people to use lifestyle as well. Now, when you do exercise, I'm an ardent supporter of exercise. When you do exercise, one thing you're doing is, firstly, you're reducing your cholesterol levels, you're reducing your weight, which makes it easier for insulin to actually work. Diabetes sometimes is caused by resistance to insulin. Insulin is a hormone in our body that controls the blood glucose levels. So people who are likely to have diabetes and early on, or who have just got diabetes and are able to start changing their life early on, they're able to reduce the need for multiple diabetic drugs. They're also able to control their blood sugars. Just having a short walk can help you control your blood sugars after a meal. Just having daily exercise can help you control your blood sugars. And as we are a country where non-communicable diseases are rising, we are all at risk of having diabetes. We're all at risk of having hypertension. So I encourage everyone to take an opportunity, maybe daily spend an hour, go for a walk, go for a run, do some kind of physical activity, because it can be actually curative in some instances. It can actually cure your diabetes, it can actually cure your hypertension in some instances, not in all of the instances, but it's quite important, and it's actually a modality in treatment of diabetes: lifestyle modification, exercise and diet.
Okay, then I would like to take this as the last question, because the doctors will need to definitely give us their parting shots. We're getting to the top of the hour. Is kidney transplant carried out in Uganda, and who are the donors? This is Aaron from Lira.
I'll attempt to answer that in terms of by directing them to the right people. So yes, kidney transplant I've seen is actually being done in Uganda. It's currently being done in Mulago National Specialized Hospital. Yes, and there is the unit there that basically runs them. So I think for more information, please reach out to Mulago National Specialized Hospital. They'll be able to advise you and guide you. But yes, kidney transplants are being done.
Okay.
Yes.
So still to you, since you're the one who's been doing the talking, what is your parting shot?
My parting shot is if someone needs intensive care, it means they are critically ill. As the doctors, we try to balance hope and realism, and we always try, whenever possible, to do what is best for the patient. But then we also try as much as possible to inform the family and keep them updated on what is going. Thank you very much.
Okay, then Alvin?
Yes, my parting shot for today, firstly, thank you for the show. Thank you for this opportunity to give us, thank you for this opportunity of giving us to share our insights on what goes on in the ICU. To the general public, my parting shot is this. We're in an era where illnesses have evolved and most of them are preventable. Let's try to be more proactive in our health. Let's try to look after one another, our relatives. Let's try to take them for medical checkups. If we feel unhealthy or we feel symptoms or we feel a certain way, please go and get checked out. To the health workers who I feel are sometimes unsung heroes, I say thank you for the extremely good job you're doing wherever you may be throughout the country. To my team at Chirudu National Referral Hospital, I commend you on the good work. I say thank you and keep it up.
Okay. Alvin has pretty much almost said it, but I would like to say, as opposed to us fearing this space, let's get to appreciate the persons behind those rooms. Because remember, that critical moment, you're not close to your patient as family. It is the doctors and the nurses who are there to ensure that they do what is within their means. But let's seek timely medication. Let's stop the self-medication. We have a very funny chain of how we go about it, but let us learn that if you have a headache, the body is communicating that there's something that is not right. Don't go and get Panadol because it's the usual, or you have it somewhere, even a lot in your bag, you're even the one distributing to friends. Let's seek medical advice as soon as possible. I would like to say thank you so much for your time. We do not take it for granted. Now I would like us to get back into a light moment where we are going to get into the lunchtime cruise. Thank you for watching. Keep locked onto UBC.
National Referral Hospital, and this is our ICU. Our ICU was developed and started in 2021 in response to the COVID-19 epidemic, and we started originally with 3 beds. We started as a 3-bed ICU, but as we could not fulfill the needs for the